morning, Dan.
Good morning, Scott.
Welcome back to this latest edition of the bookcase.
It's been a while, but it's not that we haven't been going through a number of machinations to kind of figure out where to go.
Yeah, and this particular episode, I think, is going to be a little bit different than what we've done in the past. This time, we are going to talk more about a book that we already reviewed. And then we're going to talk about a book that you cannot read at present because it's not in print.
Yeah, I was shocked when you emailed me that the author of one of the previous books that we had reviewed called Mind Games, Eric Caplan, contacted you because he had actually watched our review of his book.
It was really very flattering that somebody of his caliber had found our very small podcast and listened to it. And he not only was kind about what we'd said about his book, but he mentioned that he had this new book out as well.
Yes, and he sent us the preface to the book just so we could get a feel for what it is.
Some links as well to, because part of the story was covered on This American Life on NPR.
And the story is also referenced in another book called Strangers to Ourselves by Rachel Aviv, a reporter in New York. And so he calls the new book kind of a bookend to this book, but it's about the origins, it appears anyway, as about the origins of psychopharmacology and current psychiatric practice, which includes a very strong emphasis and focus on medications.
And for the two of us, I think, quite interested in Dr. Caplan's work because he is exploring the origin story of modern mental health care. And right now, he is teaching at Wesleyan University. Both of us were quite interested, although it's not possible to take the course that he'll be teaching this semester. I have a little idea about that. I might approach
Those
him with.
Wesleyan students who are listening, take the course. It looks really good.
Just amazing. And of course, we also think that understanding our origins is deeply important because it may help us address what is happening around the world, which is this rising mental health crisis, where the treatments that we offer, and even perhaps our way of conceptualizing mental health care, doesn't seem like it's able to address the increase in suffering. And so we're going to welcome Dr. Caplan from the waiting room into the bookcase. Welcome, Dr. Caplan.
So I'm delighted to be here.
We are happy that you're here as well. And as we both said in the intro, really surprised when you reached out to us, and much happier when you said, of course, I'm willing to chat with you both about the work that I have done and that I am doing.
Fantastic.
From your first book, Mind Games, from early on, really dealt with the origin of psychological care, or what became psychotherapy, mental health care, etc. And the question I think we wanted to start off with is, why is it important to understand the origin story of psychological care?
Well, I'm a historian by training, so it's part of my way of thinking about virtually everything, which is to say, I like to know where things that we take for granted that may seem ubiquitous today, ever present, where they came from and what led to their creation. But beyond that, many ideas and many therapies and many practices that are born 100 or more years ago are gone. In most realms of medicine, what we see is what we did once, we no longer do because we have newer and better stuff. And yet, psychotherapy, hospitalization of people with mental illness, and more recently, employing medication to treat invisible wounds, they've been around for a while, And when something new comes, the old stuff doesn't go away. And so I was wondering, where did it all begin?
Hmm. And it had a curious beginning, really. There seemed to be some cultural influences. We had this rise of people who worked more with their mind than just with their hands. We had the rise of the leisure class, economic advance, perhaps, people making more money, and riding trains.
Yeah, for much of human history, human beings don't move very fast, right? I mean, it's an odd way to put
We
it,
didn't
but
evolve to move fast, right?
that's right. So maybe the fastest a person might move is on a horse. I don't think camels move that fast, or elephants in particular. But with the coming of railroad, you got high-speed accidents. People might be traveling from Boston to New York, and all of a sudden there's this horrible train wreck, and they exit the train apparently unscathed, right? They're fine. But lo and behold, within, if not right away, within a week or longer, they start experiencing all of these symptoms that today we would recognize as post-traumatic stress disorder. Now, originally, when doctors in the 19th century looked at victims of train crashes who were experiencing, I mean, truly some horrific symptoms, especially when those horrific symptoms appeared among men, that made them look hysterical, a diagnosis almost historically given only to women, a question emerged, well, it can't be hysteria because by definition, men can't be hysterical, so something physical must have happened to them. We don't know what it is because, our instruments aren't really capable of defining the wound that must be there. So this new disease was invented called spinal concussion and then later railway spine. And it represented an incredible threat to the railroad companies, which at the time were among the biggest businesses on the planet, because they would then have to pay compensation for people who had suffered this traumatic injury despite the absence of any discernible physical symptoms, which got others to think, maybe it's not a physical injury. Maybe it's a mental injury, an emotional injury, something spawned by fright. And tort law in the 19th century is different than it is today. So if you could prove in a court of law that you suffered a physical injury from a railroad accident, a jury might award you significant compensation. But if it turned out those symptoms were attributable to a psychological wound, what today we might call emotional pain and suffering, it wasn't considered compensable according to 19th century law. So the idea that it was psychogenic, the origins of your illness, also played into the hands of the railroad companies because it would be exculpatory in terms of a legal finding.
So in other words, they wouldn't be held
They
responsible.
wouldn't be held responsible, right?
We may get there, and it seems like maybe a little bit of an analogy or a parallel to the modern insurance companies having to pay for mental care, mental illness care.
Absolutely. I mean, there's always been a reluctance, or at least a desire for major insurance companies. I don't want to open up a polemic here, but to find reasons not to pay for things. And a good reason not to pay for something, I want to be very clear, a very good reason why an insurance company should not pay for something is because it, A, doesn't work, and we can unpack what that means, or B, it's quote experimental. Like why should we pay for this thing if there are other cheaper things that we could pay for, like say for instance a pill that might more likely yield a positive result. So mental illness has always been in this sort of nebulous category of, is it medical or isn't it? Just as an interesting aside with my own insurance company, it has a distinction whether I have medical care, or then it has this whole other category called behavioral care. And so when I submit a claim to see my therapist, it's not a medical claim. it goes into a different system and it's considered behavioral. And I think that's really strange. Like there's this distinction.
As if behavioral is sort of volitional somehow, and medical is not under your control.
Exactly. In fact, I called up to complain. And I said, I don't think I have behavioral health problems. I said, I tend to behave very nicely. I have friends. I don't, I am not disruptive in a social setting. And so I really think it's utterly inappropriate for me to have to file a medical claim that in effect invites people to stigmatize me.
And with regard to our origins,
Yes.
can you talk just briefly about the relationship between these developments and the professionalization of medicine occurring, as I understand it, right around the same time, that they were fighting with traditional healers or et cetera, and had to offer some kind of contrast that seems to speak to what you're talking about. Now, there had to be a lesion in place, or a lesion that they could measure. And even if they couldn't see it, they were saying that it's just because our equipment isn't good enough to see it.
That's right. So I think here's the way to think about it, right? And to this day, what gives physicians, people who are medically trained doctors, sort of their authority is that they've gone to school a long time and they learn a lot about the human body. That's really the domain that a doctor focuses on, right? It's why all of us will go into a doctor's office, and when he, she, or they asks us to disrobe, we will, right? Whereas we wouldn't do that for our attorney or our accountant.
Hmm.
Now, for disturbances of thought, mood, and behavior, the sort of three large categories you would say of experience that comprise mental illness, it's not at least discernible to anybody that in most instances, those disturbances somehow trace back to the body. So one doesn't necessarily need esoteric medical training, medical school, to think about how you might be able to help this person. So, right, because the mind is a very nebulous category. I asked my students in my very first class, I had them do a drawing exercise. I brought all these colored pencils, and first they had to draw a body, and they all more or less drew something that looked like a body, some with more skill than others. And then I asked them to draw a brain, and they all more or less drew what looked like a brain, some with more skills than others. And then I asked them to draw the mind, and they were completely clueless. Some drew the brain again, right? So when people have symptoms, let's call them symptoms of mood disturbance, thought disturbance, or behavioral disturbance, there's no necessary reason why you would go to a physician to help you. And in the 19th century, and before that, where people who had sort of, let's call it aberrant mental behavior might turn wasn't necessarily anybody with any medical background. They might go to a minister, or they might go to various spiritual healers or lay mental healers who had their own ways of dealing with these things. And you really get an efflorescence of what's called lay mental healing in the late 19th century. And so patients, even to this day, people who are suffering want relief. And so they will turn to those who claim that they can offer it. And so it was hardly surprising that many people where medicine had nothing to offer them would then seek what I guess by today's terminology we would call alternative healers. That's overwhelmingly the case today as well. I want to be clear. It's not as if somehow physicians, despite their efforts to, if you will, acquire sole jurisdiction for the things that ail people emotionally, succeeded. They have failed. People turn to many, many different professions, some of whom physicians will consider quacks, but may actually help people. So in the early 20th century, physicians are trying to gain, as it were, jurisdiction over this thing that they call psychotherapy. And if you think about it, the word sounds very medical. Doesn't sound right. So this is something you need to be a skilled physician to do this psychotherapy.
Mm.
Today, of course, we know that that's complete fallacy. In fact, most physicians, even psychiatrists, they have abandoned any pretense of even attempting to do psychotherapy, and they leave it in the more able hands of others who have a different type of training or a capacity to empathize.
As I heard you say, that in large measure, non-physicians are providing the kind of mind emotion care that is offered in the US. And yet, isn't it also true that most still speak in a very medicalized language, that medicine is in some way ascendant, that the practice is deeply materialistic? You go to psychotherapy conferences and the hottest topic is the brain and how it functions.
Well, here I'm going to wade into contested ideological waters.
Great.
Cool.
A lot of science has what I remember once being told was physics envy. Physics, the ability to discern laws of the universe based on replicable experimentation that can then be explained with mathematics, is intensely alluring. And in some people's minds, that is sort of what all science should be. Whatever phenomena one might be observing, whether it's the stars or behavior, the possibility that could be reduced to mathematics. There's shortcuts for that. So like if you can't get to mathematical precision, perhaps you could hook something to the brain. This isn't a completely silly idea. There are many symptoms that human beings present that it turns out are rooted in something not quite normal in the brain. In early days, most of the people in mental institutions were in the final stages of syphilis. And in the final stages of syphilis, people go, not to use an appropriate term of art, but they go mad. So there's a physical cause for their mental illness. There are other diseases that lead to behavioral, let's call them abnormalities. They can be absences. So there's a disease called pellagra, which is a deficiency disease where people don't have enough niacin in their diet. That also leads to the presentation of symptoms that appear mental in nature. So the idea that there are somatic hooks to, hook is a word I like to use, that you can hook on, mental illness to something biological is compelling and often right. But it doesn't mean that everything that might appear to be a mental illness is by definition hooks onto something in the brain. It may, and maybe it's just a matter of more time, better instruments, more powerful microscopes and MRIs and fMRIs and new types of diagnostic imaging that we can't even imagine. But it could also be that it's just from the experience of being in the world and some weird confluence of genes and biology and environment that give rise to disturbances of mood, thought, and behavior. I certainly don't know the answer.
Wanted to, because I'm not sure I heard an answer to how you feel about this medical model where you have whatever the tubercle bacillus that infects the lungs, and you make a diagnosis and you have a specific treatment, and the way that mental health and psychological services have been oriented towards diagnosis and a targeted treatment. So you have depression, and we're going to do some cognitive behavioral therapy for you. What are your thoughts?
Absolutely fantastic question. When I'm almost scared to answer because again, I don't want to. I risk offending some, but I think here's what I would say. For people who have or experience the type of suffering that comes from what we today call mental illness, if they find something that works for them, that's a blessing. But the sad thing, of course, is that I think by best estimates, and apropos of what Scott was telling before we turned on the recording, there's a large percentage of people who don't benefit from any of the things that we have to offer today. As Scott points out, some people actually, sadly, may become worse off because of the experience. So a medical model is great if it helps the person who receives it. There's a poem. I love this poem by Emily Dickinson. Faith is a fine invention when gentlemen can see that microscopes are prudent in an emergency. The problem is we don't necessarily have the microscopes yet for all of mental illness, literally or, metaphorically.
I wonder if an argument could be made that psychotherapy and psychology should be in the cultural studies department.
Okay, so now I have some extraordinarily insightful, creative, and brilliant colleagues who are well steeped in psychoanalytic theory and its myriad children. And they are able to come up with extraordinarily penetrating insights to see more deeply and arrive at more penetrating insight about an area that in the absence of that theory they might not see. But for the perspective of people who are suffering, one has to parse the insights that one can generate from being well steeped in, say, psychoanalysis in particular, from the question of, is it an effective modality to treat people with serious or even minor mental illness? So were we to shift to my current project, I'm currently writing a book today about it's not a famous case in terms of law, but within the annals of psychiatry, it's an important case called Oshirott v. Chestnut Lodge. And this is a case that took place in the 1980s. And the facts are pretty simple. It's about a man who was very depressed to the point where the criterion by which one typically goes to a hospital is if they pose a risk to self or others. He had clearly reached a point at which he posed a risk to himself. And so he went and admitted himself voluntarily to what at the time was considered one of the most famous psychiatric hospitals in the United States, one that no longer exists, called Chestnut Lodge. And for anyone in high school or in college who read a book called I Never Promised You a Rose Garden, it's set at Chestnut Lodge. So the protagonist of my story, Dr. Raphael Oshirott, checks into Chestnut Lodge on January 2nd, 1979. He arrives with his father-in-law and a trusted colleague. At the time, he weighs about 210 pounds. He is not remotely psychotic, but he is in a deeply disturbed state. But when he arrives there, he's well-dressed. He's wearing a bespoke suit, something much more expensive than the jacket I have on today, which is merely from Banana Republic. And the first question he asks is, what medicines will I be given? Now, Dr. Oshirott is a physician. He's a nephrologist, so he is aware of, the role of medicine, and he is told none. You will be given no medicine, because medicine, you will need every neuron to fight your disease. And he says, what? And they say, medication will interfere in your therapy. It would hurt you. And then he's placed on a locked ward where everyone is half his age, and other than his roommate, is psychotic to the point where they're incapable of speaking. And over the next 7 months, he's treated exclusively with psychoanalysis. And he decompensates. He loses 40 pounds. He loses his fine motor skills. He becomes incapable of coherent thought. and he begins pacing. He's pacing on average 16 hours a day. The theory at this hospital, though, was that all mental illness is rooted in sort of maladaptive personality formation. That is to say, he had a bad mother. And so the purpose of the therapy there was to regress him to a state of infantile dependence, to the point of some hypothesized trauma, and then create a new personality for him from whole cloth and then rebuild him back up. And this was believed to take between 3 and 10 years to do this. At some point, his parents are incredibly alarmed, and they transfer him to another hospital, and he is medicated. And slowly but surely, he gets better. And within 3 months, he's well enough to go home. But the home he returns to, he's now been away almost a year, is a pale shade of what it once was. His wife has left him. He's lost everything. So he decides to sue Chestnut Lodge for malpractice, which is what my book is about. But the claim he makes is that he was, quote, denied the standard of care. The case centered on an evidence-based medicine, that these things don't just sound good, they actually deliver a meaningful benefit, a measurable benefit. Now, on the surface, this sounds like a great idea.
Yeah, and what I hear is you were talking was the potential for a new origin story, a new foundational.
Oh, I said, so little facts and figures. I so apologize. So in 1979, when Dr. Osheroff went into Chestnut Lodge, 1 in 20 Americans were taking antidepressants. 1 in 20. Today, in 2024, 1 in 6 are. Okay, that's an 800% increase in the number of people taking antidepressants. Osheroff wins his case. It settles, but essentially he wins. And the case sends a chill across the psychiatric profession. They realize that if they rely exclusively on psychoanalysis, Freudian psychotherapy, or other types of therapy, and do not at least explain to their patients the potential benefits of medication to treat their depression, along with its potential risks, because there are risks to everything, that they could invite litigation. So the Osheroff case, from the time of settlement until today, there's an explosive growth of antidepressants. Now, I would never lay claim to the fact that, well, that explains it. The reason I like the case as it sort of exemplifies through a deeply personal story, a sea change in the practice of psychiatry.
The sea change just wasn't in, and maybe I've drawn conclusions that are too far reaching. It wasn't just in the rise of medication, but it seemed to confirm what psychiatry and medicine had said and been arguing at the time they were trying to establish their identity at the turn of the last century, which is there was a lesion. The lesion was a chemical imbalance, and that was used to market and sell this particular product. And I only mention this because there's more to the Osheroff story than just the sea change.
Well, over the long haul, he does not fare too well, as like his life story is a sad story. So on the one hand, he's vindicated of sorts, like he prevails via a settlement in court. But whether he was preternaturally a person who suffers from various invisible wounds, or whether the 7 months of trauma in Chestnut Lodge altered his life course, is a difficult question to untangle.
I wonder if there is, and feel free to reject this framing if it doesn't fit for you, a simple conclusion to come to from the Osheroff case.
Simple one.
And a more complicated or nuanced interpretation. I'll tip my hand with the simple.
Sure.
Patients should be given a choice and informed consent. And it should always include medicine as a choice. That seemed to be what the field concluded.
Yes.
But is there in your opinion, studying this case deeply, knowing the entire history and seeing where the field has gone, is there a more nuanced interpretation that would address the question that you pose at the end of the introduction to your book, which you allowed us to read, where you say, we need to radically reconceptualize how we respond to and address the needs of those suffering from invisible wounds?
So I have given this question an extraordinary amount of thought, as have many remarkably intelligent people, thoughtful people, kind people, humane people, people with impeccable scientific credentials.
And a number of people with mental illness themselves.
Yes, and of course, many people who suffer or fortunately no longer suffer because they're receiving appropriate or effective treatment for them. Here's what I would say. In 1638, William Harvey discovered circulation, that there was a heart and it pumped blood through veins and arteries, and he discovered, you could say, what was the foundation of today, what we call cardiology. There's so much stuff that a cardiologist can do to keep that heart pumping, right down to changing it and replacing it if you have to. But you can supplement it, you can drug it, you can shock it, you can do all this stuff, and that heart keeps pumping. What we know about the brain, at least in relation to what we would call mental illness, is 1,000 years behind what we knew about the heart in 1638. And so, if the belief that the brain is the key, that may be correct, but, or I should say the brain is the organ, but no one knows, like, we're so in the dark about what connects an experience with a thought, with an emotion, the sequence of emotions, that sure, it may be the Holy Grail, but I mean, the story of the Holy Grail is we never find it. So what my beef is the wrong word, because I benefit immensely from psychiatry. I take a medication. I have a psychiatrist. I am grateful that I am one of the lucky ones. But the pretense of the profession, the thought that we are finally arrived at some point where we're just on the cusp of solving whatever that problem is, I think that's wrong. I think there needs to be a little bit of humility in the face of this profound mystery. And it's wonderful that treatments work for some people, but the explanations as to why they work are, in a word, ludicrous. I mean, a chemical imbalance implies that one could find all these chemicals in the brain and, put them on various scales. And if you just got a little bit of the serotonin and dopamine and whatever, and lo and behold, you got a balance. I mean, that's just a metaphor, right? I mean, it's predicated upon earlier notions of humoral medicine going back to the 1st century AD, where you had a system of, the 4 humors. So, I mean, it's a great metaphor, and maybe it helps sell drugs, but nobody who works at a pharmaceutical company, no psychiatrist or researcher believes that there's ever been a, quote, chemical imbalance. But to let psychiatry off the hook with cholesterol, I don't know if you guys are my age or thereabouts, like I take medicine for cholesterol. I don't know if either of you do, none of my business.
I do.
Okay. So we tell the story of, quote, good and bad cholesterol, right? LDL is bad cholesterol, HDL is good cholesterol. Well, you gotta get that's a metaphor too. And it's a very compelling story, and it helps sell drugs, because drugs that lower cholesterol more than others are, quote, better drugs. But some cardiologists might tell you, well, the real problem is inflammation, and what statins have a remarkable capacity to do is reduce inflammation. But the cholesterol, good, bad, I mean, that's like, kindergarten. So I mean, psychiatry, on the one hand, you can say it's different than the rest of medicine, but it has a lot of striking similarities, right? We understand how our bodies work, which is incredibly complex via metaphor and stories. I don't know that there's ever any way around that. So whether I'm messed up because of my serotonin imbalance or because of my Oedipal fixation, I mean, they're both stories.
When I listen to you speak, I'm reminded of something I hear from people who are navigating both our healthcare and our mental health care system. They, like me, would like to believe that they can tell me their issue, or I can diagnose it and I can open the book and find the appropriate treatment. And discovering otherwise can be dispiriting and lead to a process of trial and error that sometimes results in less than adequate compassion towards those that are suffering. And in part, fit or feedback informed treatment has stepped into that breach, so to speak, as a way to say, at least, for example, in Dr. Oshrof's case, if we would have been asking and monitoring, as opposed to following this ideologically driven point of view, we would have seen early on that what we were doing was not only not helping, but making things much, much worse. Yeah. And been able to at least offer an alternative, whether that was medicine or, frankly, a tarot card reader, that somebody, anybody who might have had something to do or say that would have led to his reconstitution at whatever adequate level it could have been reconstituted.
Yeah, I mean, compassion across all of medicine has to be fundamental.
I think that may be a good place to pause for now. We've taken your time for a complete hour. I feel like, and I'm sure, Dan, you feel the same, we've barely scratched the surface of your study of the history of psychiatry in our professions and its potential, how it might inform what we're doing now and in the future. I would hope that you might be willing to come back once the book is out.
I would be delighted, and then we can talk about that, and you can, yes, and that would be wonderful, and maybe the people who listen would buy a copy.
Yeah, that's good.
Thank
Thanks,
you so
Eric.
much. Bye-bye.
Hey, Dan.
Good morning.
Good to see you again. I think it's like a week or maybe a little bit more since we interviewed Dr. Caplan.
Yeah, it hadn't been very long. I know that.
And so now we have read his first book and we read the intro to his forthcoming work, as well as a review he did of
Rachel Aviv, a book called Strangers to Ourselves,
which I know has been on our list to consider reading and doing a review of. Personally, I think it's an interesting book. And now we've had a chance to edit the video, which we spend a lot of time on, removing the hims and haws and uhs and you knows, just so that there is a smooth flow. The benefit of that is that I'm always in a reflective mode when I do that. And I'm thinking about what he's saying, I think, a bit more closely. And I know you've done the same, watching the video. Where are you at?
Well, I think the editing was fantastic. I think the video had a nice flow to it, and it covered some pretty good ground. I guess I'm wanting more. I feel like there's some, I guess I might call them unanswered questions, some details that need to be fleshed out a little bit more.
He certainly seems like he's onto something here. There is something rotten in the state of mental health.
Absolutely. I must confess, I love the historian's perspective on it, because concept that comes to my mind, he doesn't really have any skin in the game in terms of a biased opinion about something other than his own experience.
Yeah, yeah.
So he can kind of read with a fresh perspective that I think is fantastic. He's a wordsmith. I mean,
Yeah, he is.
even during the
Unbelievable
video,
writer.
it comes out that he even speak off the cuff in a very educated and thoughtful manner.
Yeah. I'm thinking of the questions that are unanswered, though. He said a number of things about mental health. So one of them is, and I wrote it down at the time, our explanations about how our approaches work are ludicrous.
And you and I both know how true that is. I mean,
Yeah.
From my perspective as a physician, this idea of a chemical imbalance, you can just put these chemicals on a scale and dial in the right amount is crazy.
Yeah.
And at the same time, maybe half of people in our country believe it to be true, or certainly
exactly.
at least half of the people who take mental health medications to manage their conditions.
That idea certainly slipped from the physicians' offices into cultural discourse in a kind of a popular way. And from the psychotherapy side, the stories are ludicrous. We have hundreds of different treatment models. Tests, head-to-head comparisons show that they all work, even though many of them have nothing in common in terms of their explanatory framework and associated techniques, everything from moving your fingers all the way to talking to an empty chair. It's just irreconcilable, combined with the fact that the research indicates the outcomes of psychological care haven't improved in more than 50 years. And in the last pages of his introduction, something which we introduced and asked him about in the video, he says, to address our mounting mental health crisis, we need to radically reconceptualize how we respond to and address the needs of those suffering from invisible wounds. That's the thing I think he's on to. Yes, we need to.
But I guess I'm less than satisfied with the answer that we came up with. I didn't hear a radical reconception.
But I also am deeply mindful of something else he said, which was, we are in the dark and maybe decades and centuries away from understanding what I believe, or took to him to say, that of understanding the brain, which is this view of where these mental and emotional suffering might be taking place.
Yeah, and that smacks of materialism and reductionism in a way that has not sat well with my clinical experience. At the same time, we know quite a bit about how the brain and the mind function. But I don't know how much closer that's gotten us to the holy grail of fixing mental health problems.
Yeah. And his answer seems to be, at least at present, and I guess it's a pragmatic one rather than a philosophical one, that whatever works, if a person is able to find something, then that's acceptable.
Yeah, and that is kind of what FIT is about, feedback informed treatment, where you're measuring outcomes and you're engaging in a dialogue with your patient on where they are and how the relationship is, where what their goals are, what the means to get there is, what the role is to be, all of the stuff that we talk about in FIT.
And that outcome becomes the central focus. It's not the process by which you achieve those outcomes as much as it is, are they being achieved? Which means that beyond psychiatrists and psychologists and other mental health professionals, if we take this to its logical conclusion, we're also talking about ministers, friends, tarot card and mind readers, spiritual advisors. And here's, I think, a quote he said: people overwhelmingly seek healers instead of therapists. And that's a truism. Most people who have problems don't go to see a therapist. Psychotherapy is the professionalization of that domain, healers.
And it's not only the professionalization, it's kind of the medicalization of it.
Yeah, and the exclusion of others who don't fit within that medical framework. And hey, Dan, I half suspect that he wouldn't disagree with most of what we're saying.
No, I think it definitely fits with his historian viewpoint.
And so is that the next step? Maybe we reach out and see what he thinks. We share some more about fit. Maybe we share some more about broadening the lens of mental health care to include healers that fall outside the medical view.
I think so. I did find myself during our interview of him wishing that he knew some more about fit. Be great to have him on a training, honestly, or I don't know, present some cases to him to get his perspective.
Someone who has the historical lens that could tie the developments that led to fit all together. Well, then maybe we reach out and check in on that. And this is also, I know we've talked about seeing what would be possible about offering perhaps an abbreviated version of his course for the people who listen to these particular recordings, because both in the live recording we did and then just in the personal email exchanges and then before and after the interview, interacting with him was delightful.
Yes, absolutely. Agreed.
Let's do that then.